When we are discussing the field, as you listening of long discuss how to put of people. So I guess we could talk about it.
My patient, 49-year-old male, resident of Satara, serving air warrior, a graduate by education, informant self, reliability good. He was admitted on 4th June 2024. He presented with complaints of breathlessness on exertion of 6 years duration, angina on exertion of 4-year duration, palpitation of 2 years, and pre-syncope of 6-month duration. My patient was apparently asymptomatic till 2018 when he started having breathlessness on exertion, which was insidious onset, progressing from NYHA class 1 to class 2. Initially, he was able to perform ordinary physical activity without any symptoms, but over a period of 1 year, he became breathless with ordinary physical activity. His symptoms remained static till 2022, when he was admitted at Command Hospital Central Command with worsening of breathlessness to NYHA class 4, which was associated with PND, followed by orthopnea and palpitation at that time. He was managed at Command Hospital Central Command with clinical improvement, underwent CAG, was advised some cardiac procedure but was not willing, so was continued on medical management, and his condition remained static till present admission in June 2024, when he again had worsening of dyspnea to NYHA class 3 associated with PND and an intermittent palpitation. He presented with heaviness of chest of 4-year duration, which was retrosternal, squeezing in character, exertional to NYHA class 2, and relieves with rest. Also complained of palpitation, which was intermittent, sudden onset and offset, not related to exertion, with no post-palpitation diuresis. He complained of multiple episodes of dizziness, 5 to 6, feeling of lightheadedness with sudden blackout of vision for 4 to 5 seconds, not associated with fall, which recovers spontaneously and without any limb weakness or seizure-like activity. Coming to negative history, he gives no history of swelling of lower limb, no history of bluish discoloration of hands and feet, no history of diurnal variation of dyspnea, any wheeze, cough, expectoration, fever with evening rise of temperature, no history of facial puffiness, hematuria, frothy urine, no history of abnormal sweating, tremors, and heat intolerance, no history of cold intolerance or constipation, no history of upper or lower limb claudication or any joint pain or rashes.
So I request Professor Rajesh.
Dyspnea can be divided into acute dyspnea and chronic dyspnea, sir. Acute dyspnea can be because of ACS, pneumothorax, pulmonary embolism. Chronic dyspnea can be divided into system-wise. It can be cardiovascular, which can be because of coronary artery disease or a valvular heart disease, cardiomyopathies. It can be because of a respiratory cause like asthma, COPD, and any restrictive lung conditions. It can be because of anemia. Then it can be because of neuromuscular causes like GBS. All this can cause.
Yeah. So maybe in cardiac congestive heart disease, basically can be expression or can be reducing and valvular heart disease. Then cardiomyopathy, CM, AGM, coronary artery disease. Then dynamic mention of CM. Then congenital heart disease. They develop cause of these two. They can present with the burden of PA. Then the respiratory cause that's not very we have to keep in mind. Then other problems like anemia again is a very important topic in all this. So, Vijay Prashant, how do you grade this?
So there are several scales for grading the dyspnea, sir. Sir, initially we use MMRC, modified MRC scale, sir. Then we have Borg scale. We have American Thoracic Society scale, sir. We have visual analog scales, and we have specific activity index scale, sir. For cardiac conditions, we have NYHA, sir.
Sridhar, so just tell me grades of grades.
So in New York Heart Association classification, we have 4 grades, grading from the NYHA 1 to NYHA 4. NYHA 1 is in a patient with
So what cardiac system it covers?
sir, it covers breathlessness, palpitations, and fatigue, and also angina. Sir, it is 1 is patient with known cardiovascular disease with no symptoms. 2 is patient with cardiovascular disease with mild restriction. However, they are normal in the rest. 3 is moderate physical activity, they are finding restriction. And 4 is even they are having symptomatic at the rest, sir.
So basically, in this, we cover 4 cardinal symptoms. This neurological classification covers 4 cardinal symptoms, in which basically it defines whether how much extent of activity one can do and what level of activity they become symptomatic. So accordingly, class 1 basically on exertion and the class 4, which they are symptomatic and even at rest, they can't perform any activity. The feeling of blows, they start developing breathlessness. So, Major Vikas,
Major Vikas, what are the characteristics of angina?
So angina is defined as retrosternal chest heaviness or discomfort that is aggravated by exertion or emotional outburst and is relieved with nitrates or when the
By taking rest.
or taking rest.
Okay. So basically, angina is defined typical sensation of heaviness or some squeezing or some one feels that he is having some weight on his chest and they keep like hand like this. And sometimes they even feel burning, but sometimes with dyspeptic symptoms, what they feel something, some discomfort in the chest. Usually it aggravates with exercise or taking meal even in cold. Then by taking rest or by taking nitrates, it reduces. If all these characters met, then it is called typical angina. And what is atypical non-cardiac? When you think that it is not a cardiac pain?
Sir, if 2 out of 3 are present, then we call it atypical. If 1 or less than 1 are present, then we usually classify it as.
Okay, so non-cardiac type of pain. Major Prince? Major Garvita? So what are the character when patients say he came to you with pain and you say no, this is not cardiac. So what are those characters of pain?
Sir, that could be either at the precordium or it could be lateral. It could be sharp shooting pain, which increase on respiration or increase on palpation or increase on cough or decrease on lying on the same side.
Basically, sometimes patient usually come and they point towards this thing, they point toward precordial region or sometimes in the epigastrium, they point. And usually they say this comes for seconds. And angina does not come for second, it lasts at least 5 to 15 minutes. In case if it is a chronic stable, or in case of unstable angina or myocardial infarction, this continues. Angina lasts more than 20 minutes, 30 minutes. Yes, next slide, please. So for angina, as he has shown Canadian classification, squadron leader Abhishek, what is this CCS classification of angina?
So it has 4 classifications, sir. Class 1 is when angina is present with strenuous activities. Class 2 is with angina with moderate activities. Class 3 is when angina is present with less than moderate activities. And class 4 is when angina is present in rest. And class 1, sir, angina is when there is doing strenuous activities or rapid activities. In class 2, when the patient has features of angina while walking in cold or either in the wind or after meals.
So mainly now we have displayed the slide, so one can go through it. So what is the difference if we say how this CCS classification is better than NYHA classification for angina?
Sir, in NYHA, sir, there is, they have given only regarding limitation of activities. They have not giving the quantification of the activities which can be done.
Yes. So it quantifies this thing. And when we say this thing, 1 or 2 flights, 1 or 2 blocks, how much is the distance?
So 1 or 2 flights generally includes about 8 to 10 stairs in one flight, sir. And 1 to 2 blocks, it's about 50 to 100.
Merely 100 to 200 meters.
Yes, sir.
Basically, this is a Western taken from Western culture. They had blocks in the buildings, so accordingly, it is 100 to 200 meters. Next slide.
Coming on to past history, there was no history of diabetes, hypertension, no history suggestive of rheumatic fever or recurrent LRTI during childhood. Treatment history. In 2022, when he was admitted at Command Hospital Central Command, his ECG showed atrial fibrillation with fast ventricular rhythm. He was given DC cardioversion. His 2D echo showed EF of 65% with significant left ventricular hypertrophy. He underwent coronary angiography and was advised further intervention, which he denied at that time, and was managed with medical management. He consumes mixed diet, normal appetite, normal bowel bladder habit, normal sleep pattern, never smoker, denies consumption of alcohol or any drug abuse, belongs to upper middle class on modified Kuppuswamy scale. He was born of non-consanguineous marriage with no family history of hypertension, diabetes, or cardiac disease. There was no history of sudden cardiac death in family members.
So, Major Sudhinder, please summarize the case.
49-year-old person, he presented with a chronic dyspnea for last 6 years and angina symptoms for last 2 years and 4 years and palpitations for last 2 years and syncope, dizziness and syncope for last 6 months with a previous history of known cardiac disease in the form of hypertrophic heart disease for which he underwent.
So, how you are saying hypertrophic cardiac?
Echo it is.
Echo is shown just LVH.
LVH.
Next.
Then after that, now he's presented with it's acute exacerbation.
Just display this, right? So basically, our patient presented with breathlessness 6 years, angina 4 years, palpitation. These are typical symptoms of pre-syncope, and he had one decompensation. So what do you think the cause of decompensation, Major Srinu? Why he had decompensation 2 years back? So even we have explained in the history. Even we showed the ECG. So he had atrial fibrillation at that time. So atrial fibrillation can cause decompensation. What are the other causes of decompensation of dyspnea in cardiac cases? Major Francis?
Sir, the causes are physiological causes like anemia, sir.
Anemia, yes.
Decompensation. And the infections like pneumonia, sir.
Very good.
And she is on medication, sir, but it's not maintaining the drug poor compliance, sir.
Drug poor compliance, yeah. Or arrhythmias. Basically, yes, these 4 things you have to keep in mind. So, Major Ram, what are differential diagnoses in our case? What do you think from the history?
So historically, the patient is having angina, sir, and he
basic main symptom dyspnea, then angina, then
the pre-syncope, sir.
So, in which subset do you think all these?
Three will be present in a aortic stenosis, sir. In the valvular heart disease can be.
So one can be valvular heart disease, okay.
Aortic stenosis, sir.
Okay.
It can be coronary artery disease as well, sir.
Okay.
And it can be any cardiomyopathy also.
Okay. Sir. Any other thing?
Acyanotic.
Okay. So coronary artery disease. Why we are thinking coronary artery disease?
Sir, he is having this angina.
So mainly he had dyspnea initially to begin with, the dyspnea which can be angina equivalent symptom because it was NYHA class 2 only. Then later on he developed typical angina